I'm your host, Dr. Holly Thacker, and I am happy to be back in the Sunflower House. And on this new podcast, I am interviewing a recurrent guest who we interviewed last season, Dr. Kristi Tough-DeSapri. And we will be talking all things what's new in osteoporosis. It's May, Mother's Day month. It's Nurse Appreciation Month. And importantly, it's Osteoporosis Month. And this is a condition that affects so many women that's really near and dear to Dr. DeSapri and my heart. Mm-hmm. Dr. Kristi Tough-DeSapri is a board-certified internist specializing in midlife women's health and osteoporosis. She graduated cum laude from Tufts University, and she attended medical school at the University of Health Science Center in San Antonio. And then she did an internship in obstetrics and gynecology at NYU and a residency in Lenox Hill Hospital. I am very proud to say that she completed our 2-year interdisciplinary fellowship in specialized women's health at Cleveland Clinic. And I've had so many fabulous graduates of the program, but I have to say she really ranks right up there. I was amazed at everything that she was doing and all the stuff that she accomplished. And even how one time she walked home in her high heels in a snowstorm. I was afraid she wasn't going to leave New Manhattan and all that high fashion and come to Cleveland. And she did. And she left her fiance, who she later married. And she's another woman after my heart because she's a boy mom of 3 school-aged boys, and they are just the cutest boys. Hopefully you can catch a picture of some of them on her social media, which we'll get to. So she's been very busy. She started her own practice called Bone and Body Women's Health in Chicago's North Shore area. And it's a concierge midlife women's health practice focused on consultation and management of all the things near and dear to my heart: perimenopause, menopause, osteoporosis, and sexual health. And she is a national leader in the field of osteoporosis and menopause management. She's on Instagram at Bone and Body WH. We'll put that in the show notes. And she's a busy lady and very successful. Welcome, Dr. Tough-DeSapri.
Oh, thank you, Dr. Thacker. I could say likewise the same about you. Everything I've learned started from the Cleveland Clinic, and if I could be in Cleveland, I still would be there. I loved the learning and the collegiality and just the passion that you have for this field and continue to. And I think all of us fellows and all the people that you touch are so, and including with this podcast, are so grateful for the work you do and continue to do. In women's health, we need lots more people in this field. So that's why we're talking about educating the masses today too.
And, you know, I've only had sons, of course, so I never had any daughters, but I always feel like I still have some daughters all around the country. And I love to get the holiday cards and hear about new additions to families and new practices. And it's so exciting. And it is important that we're talking about osteoporosis. And I think thanks to one of your interviews you did with us last season, we were actually named one of the best podcasts in osteoporosis. And it hasn't been really a sexy topic, but I always tell women it's hard to be sexy if you're outliving your bones and they're crumbling, literally. And so many women don't even know they have osteoporosis. And even if they break a bone and have a fracture that needs clinical care, they still don't always make that connection. So tell us about how should women know if they're at risk of having osteoporosis or if they indeed have the disease of osteoporosis.
Yeah, you make so many good points there. And I think that's a lot of what we do, educating, our patients in clinic, but also just like when we look at mainstream social media and just talking about osteoporosis isn't a sexy disease, but really what midlife women's health condition is made out to look sexy. I mean, we need to think about living, living with our bodies, living with our bones, aging powerfully, aging gracefully. And the way we do that is multiple things, right? We think about our cardiac health, our breast health, treating our vasomotor symptoms, all of these things, sexual health. But the bones tend to be forgotten about, and that tends to fall to the bottom of the list. I always joke, like along with like the health maintenance options, like, are you getting a colonoscopy and have you been to the dentist? And then patients sometimes are asked, what about a bone density? But often it's too late. So how do you know when it matters? Well, like everything else, it probably matters before you're even thinking about it. So at midlife or menopause, perimenopause, wherever that is, and generally that for most women is between 30 and 55, that they're entering the menopause transition, that we should be thinking about bone health. It's actually one of the reasons I started my practice, which having bone in the name, I people told me, don't put bone in the name, like it's not that great, it's not that catchy. And I was like, no, it has to be in the name. And so bone, actually my husband came up with the name of the practice, so I do have to give him some credit for that too. So I had smart bones and strong bones and all these things. Like you have these messages of strong aging strength, and with strength in the Speaking of Women's Health platform. But the reality is many women should have a bone density before they know it. So what do our guidelines say? They say that you should have a bone mineral density around the menopause transition. If you have any risk factors for bone loss, the number of risk factors for bone loss are lengthy, generally being female, postmenopausal, lower body mass. If you've had a fracture, that's a direct sign that you have low bone density already. Certain family conditions, genetic conditions, certain medical history, surgical history, all of these things together are very important. That's why we take detailed reproductive histories and medical histories, because all of these things matter both in your regular metabolic health and your menopause health, but primarily in your bone health. And I'll also tell you, when I see my patients in my practice, at least a half or more have low bone density even before they're starting menopause. And that's actually what the national and world statistics show. So we really don't need to wait till we have a fracture. If you've had a fracture, that's the most important. One of the most important things I want to say today is that means your bones are calling out to you. They are telling you, you need an evaluation, even if you're 40, even if you're 50. Generally those can be stress fractures or fractures of the distal radius. I hear all the time, fracture of the forearm, vertebral. I just got a call from a patient with a vertebral fracture. These are not just silent fractures, although we think they are. They actually have quite significant sequelae, and we can prevent them and diagnose osteoporosis or low bone mass early. And that's really important.
Yes, it certainly is. And do you want to talk about what's involved in getting a bone density scan?
Sure. Yeah. So I think oftentimes now, we're hearing more about bone density or scanning for body composition. And I think that's very interesting that we've moved, using DEXAs for body composition. But what we're talking about with a bone mineral density is actually checking your bone strength. And we can do that by scanning both your spine, your hip, sometimes your forearm. Sometimes we can even check for fractures in something called a VFA. This takes 10 to 15 minutes in qualified hands. It should be done at a site where they're used to doing this. They hopefully have some certifications to do this. This is a thing that, society, both Dr. Thacker and I ascribe to, and it's important that the quality of the test done is so you get the accurate measurements and the accurate results, so that actually makes a meaningful difference for you. This is painless. It's low radiation, less than 0.1 microsieverts or millisieverts, which is a very low amount of radiation, almost equal to that of a mammogram or less. So this is a very simple, easy test. I think the hardest part is sometimes finding a provider to order it for you. So sometimes my patients are advocates for themselves. Like, I have these risk factors. I think I need a DEXA. I'm entering menopause. I'm low body mass. Oh, I have Crohn's disease. I think I have low bone density. I've not been able to tolerate milk. These are all some examples, and there's so many more of, why you need a bone density. And sometimes that's advocating for yourself, or sometimes that's hopefully an astute clinician who's listening to these podcasts and learning that bone health matters, just like getting your mammogram matters, just like we asked when your last cervical pap smear was, and are you going to the dermatologist, and all of the things that we do to make sure that we're aging in all these areas well, and with a prevention mindset.
We'll be back after a quick break. Hey, quick question for you. Are you someone who wants to be fit, healthy, and happy? And what if I told you you could get your dream body by simply just listening to a podcast? I'm Josh.
And I'm KG, and we're the hosts of the Fit, Healthy, and Happy podcast.
Listen, we get it. Fitness isn't easy. Carbs, no carbs.
Just stop, okay? It doesn't have to be that complicated. And that's why we made this podcast. We get straight to the facts so you can become your best you.
So the way to check us out is click the link in the show notes or search Fit, Healthy, and Happy podcast on any of the major podcast platforms. We'll see you soon.
And can you talk a little bit about fragility fracture, low trauma fractures, why so many women who break bones think that it's because they fell or they had some low degree of trauma and they don't seem to connect? That's not normal.
Mm-hmm. So yes, thanks. And it's right. We're moving away, thankfully, in the field of osteoporosis, which I think sometimes is a little bit separate from the field of women's health. I mean, we have a lot of great endocrinologists and rheumatologists and orthopedic surgeons who manage a lot of osteoporosis, but we also need a lot more women's health providers that are interested in this area because we are at the front lines of seeing women who might have had a fall or a fracture like a distal radius or forearm fracture or a pelvis fracture or recurrent stress fractures. Exactly. So we've moved away from using the word fragility because who wants to be fragile? And, that doesn't really describe what's happening. We want to use low trauma, meaning a fall from a standing height or less. And that can be even, and surprisingly, even fractures like patients who fall off their bike or, higher trauma fractures, we think maybe being, falling from 4 feet on a ladder. When we look actually at the bone mineral density of women who've had a high or low trauma fracture, they seem pretty similar, that there's low bone density in both of those subsets. So really any fracture needs to be evaluated and your bone health needs to be looked at. And so why we don't know is because I don't think there's enough public knowledge out there about this. And why we don't know is we have no symptoms of having osteopenia or osteoporosis. So oftentimes, and I know we worked on this when I was a fellow, patients come in and say, oh, my left hip has been bothering me. And I tell them they have osteoporosis. And they're like, exactly. That's why I've had pain. And I think, of course, I have the same questions, probably silly questions when I go in to ask my dentist something. And it's unfortunately, there are no symptoms of osteoporosis or osteopenia until you break a bone. Plenty of us have osteoarthritis or joint pains or labral tears or other issues causing bone, pain or joint pains, or muscle pain. But osteoporosis is, unless you've had a fracture, which those fractures are painful and are not painless. And vertebral fractures, which are spine fractures, can cause height loss, can cause, worsening of respiratory conditions, chronic constipation, not to mention just, again, aesthetic changes, and oftentimes require surgery or strong pain medications, a lot of office doctor visits, and a lot of times people don't walk or live independently again, particularly after things like hip fractures, which carry a significant concern, especially for women in the postmenopausal years. So these are not just silent when you actually have the fracture. And I think that's what a lot of women who have osteoporosis come to realize. When they actually have a fracture, they're like, this is significant. This is big stuff. And they want to educate their friends and others and themselves to actually think about evaluation and then treatment as well.
I'm so impressed when I have a patient come to see me who specifically presents because they're interested in their bone health, maybe because they took care of their mother or some other female friend or relative and saw the ravages. And we really want to get people to get evaluations and treatments long before that. And you mentioned the aesthetics, and some of my most popular podcasts are on hair thinning. Which having no hair isn't going to affect your lifestyle or your length of your life, rather. And the skincare, all that stuff is very popular amongst women. And it amazes me how many women don't realize how their whole body changes when they get kyphosis and they're humped over and their heart and lungs and everything, abdomen pouches out, everything's all squished together. And so I wish that if people want to be aesthetically focused, that they would also realize that your skeleton is so important.
Mm-hmm.
So tell us what things women should watch out for in terms of osteoporosis related bone problems.
Mm-hmm. It's so I would just want to underscore what you said, Holly, too. It's so important because, right, our posture is related to our height. And, when I was training at the Cleveland Clinic and we would measure, women yearly on a wall mounted stadiometer, which is, we're getting out in our science world here. But again, that is really important because many women don't know their height, or they've been measured incorrectly so many different times. And it's very important to measure, be measured at least once yearly, and obtain, really know your height. And, not, we always say, don't cheat or give yourself the hair height or whatever. And really know your height I always say, what was your height when you're 40? And then let's measure you correctly today. And sure, if we look through, the medical record, there's like 15 different heights and they're all sort of confusing, but we should get a good height and a good height estimate to know if you've lost, more than 1.5 inches of height since your adult peak, or you're losing 1 inch of height over yearly, and we think it's measured correctly. That can be signs of silent vertebral fractures or silent bone loss from these fractures that can either be of the upper spine, the thoracic spine, or the lower spine, or the lumbar spine. And you're right. I mean, this does make a difference. Also, patients walking with cane or assisted devices. I mean, we know that when hip fractures, when women have a hip fracture, they cannot walk independently. 25 to 30% don't walk independently. So that's an assisted device. That's trouble, with your daily activities. That's loss of independence. These things maybe not are aesthetic, but really they are, again, quality of, and sometimes even quantity of life affected. And I think a lot of people now care more about posture. We're certainly hearing more about strength training and strength, and maintaining your muscle mass. And I think the muscles have somehow, are the muscles and bones have to be thought about together, right? So strengthening your muscles is going to strengthen the bones around them, help with posture, coordination, confidence, all of these things. We know that resistance training, again, helps strengthen the type 2 muscle fibers, strengthens the cortical bone. I mean, there's a lot of more discussion in the health science and nutrition science world about these things, but we have to remember that from the beginning, this has always helped bone health. So this is not anything new.
So, you are listening to the Speaking of Women's Health podcast. I am your host, Dr. Holly Thacker, and I am interviewing osteoporosis and women's health expert on the North Shore of Chicago, Dr. Kristi Tough-DeSapri. And we're talking all things about the diagnosis, the evaluation, and the risk factors. Tell us about what happens after having that first fracture, like breaking the wrist or having a lumbar compression fracture.
So oftentimes, when osteoporosis is diagnosed with a fracture, we have to do a DEXA scan. And generally, again, we're not using that for diagnosis. We're using that to know sort of where your bone mineral density, is now, and what your bone strength looks like, or maybe even your bone quality. And so we can make treatment decisions. Treatment decisions always start, and I think this is, so important with, lifestyle, with evaluation of why this is happening. Is it just because we're, postmenopausal and female and there's a genetic component, or is there an underlying cause we can fix or treat? We obviously, that's a lab and blood test workup, and sometimes a urine workup, and that usually requires some sort of specialist, but not always. You can find, people who are, more adept at bone health in lots of different communities, hospitals, as well as bone health clinics across the country. And then we always think about things like lifestyle, like calcium, vitamin D, exercise, fall reduction, the things that we've talked about now. So those are always the mainstays. But the most important thing to understand is that once you've had osteoporosis, and this is sort of equated to, a bone attack, like a heart attack in the cardiovascular world, this is telling us, again, your bones are calling out to you. So just calcium, vitamin D, and exercise, although good, important foundations, are not going to generally reverse the bone loss that's happened, and are not generally going to treat that fracture and prevent the next fracture. So I have a lot of patients who want to do things natural ways. I am all up for nature. And I know you are as well too, Dr. Thacker. You think it's important to do things naturally. We give bioidentical or biosimilar hormones. We try and I recommend vitamin D, both from supplements and also from sunshine. I mean, there are a lot of things that we recommend, but when it comes to many things, especially bone health, calcium, vitamin D, and exercise alone, and we can add other things like collagen and prunes and vitamin K and strontium and all sorts of other things to that list as well. And all those some of those can be helpful. They're not going to prevent another fracture. We have large the best type of studies we have in our medical world, randomized control studies, meta-analyses, these big studies that look and show that that doesn't help prevent another fracture. And 1 in 2 women will have an osteoporosis related fracture in their lifetime, 50%. And if you've had a fracture, your risk of having another fracture is up to 80% and sometimes even higher depending on the site. So let's prevent that next fracture. And the way we do things are we think about our FDA approved efficacious treatment options, just like we would with any condition. If you had a heart attack, you would get sent home from the hospital with a beta blocker and a statin and an aspirin and, a cardiac physical therapy follow-up. And if you have a fracture of your hip, you should be sent home with all of those things as well. Medications, physical therapy follow-up, calcium, vitamin D instructions, and an FDA approved therapy to reduce another fracture. And that really is across the board. And so when we think of how we treat, we really think of, again, your history, your risk factors, what we're trying to prevent in terms of the next fracture.
Now, you mentioned strontium. I'm certainly not a fan of that because being a heavy metal and it's deposited in bone, it actually increases the bone density. So it makes comparisons, I think, not really valid or accurate. And I imagine in your practice is very similar. You like to do the bone density on the same machine with an ISCD certified tech, doing your precision testing with your Phantom spine every morning and seeing if the person in 2 years is the same, which is fine if there's no fractures, better, which is usually great, or if they're worse, that situation.
Yeah, absolutely. And yeah, the strontium discussion, I think, you can always find literature on both sides, just, like everything, but the strontium that we have in this country, strontium citrate, not strontium ranulate, really there's few studies. Most of it makes no significant difference in the bone mineral density, or if it does, right, like you said, it's sort of displacing calcium in the elemental table and can make the bones appear stronger, but not actually the strength not be there. The bone mineral density is not mineralized as well. And they've actually pulled the strontium ranulate off of the market in Europe for cardiovascular concerns and events. And so again, I think we're getting back to basics like calcium, vitamin D, protein intake, resistance exercise, fall reduction, and then again, medications to kind of, I sort of say, like, seal the deal. Like, we know, even when we think about things like we're both proponents for FDA approved, hormone therapy, both, bioidentical hormones, which can be FDA approved, or, oral medications, etc. And we know that even those medications reduce, and hormone therapy reduces the risk of fractures by 30% from that lovely large Women's Health Initiative study, and improves the bone mineral density. And those are for women who are at maybe lower risk for fractures, or have or using hormone therapy for prevention of osteoporosis. But for women who are high risk, like the woman you mentioned who's had a fracture, other medications can reduce your risk of a fracture by 80%. So some of the bone building medications, we call those osteoanabolic medications, actually filling in and creating new bone, stimulating our own bone, like our cells called the osteoblasts to build new bone, the osteocytes, working on preventing the osteoclasts or bone forming cells that are much higher after menopause. So we have lots of ways, just like we do in other treatments and conditions, to really use our own body's cells to make them work better, so we can support our structure and build the bone density back.
It always amazes me how, and I understand why health conscious people who want to stay vital and work to reduce the vicissitudes of aging like to focus on lifestyle and natural things. I completely understand that and embrace that as being strong, healthy, and in charge, our motto. But it amazes me how women will just take a statin when we have no primary prevention evidence for heart disease. And because it will lower my cholesterol. They can see that number. And yet when you show them, and I show them the pictures, as I'm sure you do, and you were a very early adopter of the trabecular bone scoring, which looks at the microarchitecture of the bone, which is 40% of the strength, that they're a lot more suspicious about taking the medicine, or they somehow think that calcium and vitamin D is the medicine when we all need calcium and vitamin D, regardless, for lots of things, not just bone health.
Right. Yes, and absolutely. I mean, I think there's a place for everything, right? And so I think we're saying it's not one, take one or the other. There's a, there's a place for everything, and we're both working very hard. I'll give a shout out to Dr. Phil Sorrell and our menopause learning series that we're doing for clinicians, physicians, nurse practitioners. I even have some medical students and PAs and even some physical therapists that are taking the course and listening to hear more about how we think about primary prevention of things like heart disease and bone prevention of osteoporosis, and treating women appropriately with hormone therapy who it's indicated for. And so I think that yes, we have to use a very fine tooth comb when we ask what's the medicine for and what's the research behind it. And that's would go the same if you were to use a supplement, right? Or you would use a natural method. What's the research behind that for the condition I'm trying to treat?
And what Dr. Tough-DeSapri is talking about, because we have lots of physicians and APPs and nurses and pharmacists as well that tune in to our Speaking of Women's Health podcast, is a series of free CME. And I even have non-medical people like to watch the videos. And Dr. Phil Sorrell, who is like a giant in the field of menopause and hormone therapy, has assembled lots of experts from around the country. And Dr. Tough-DeSapri is co-directing this latest round we're doing, and anyone can go on menopauselearning.com, and there's just a great selection of scientific articles, videos, and interaction. So for any of those of you inclined, I would definitely strongly recommend that.
Mm-hmm.
So
Thanks.
let's talk about some of the latest medications and treatments, how you structure it. But actually, right before we get into the meat of everything, the bones of everything, rather, on treatment, do you have any comments about how trabecular bone scoring has affected your practice? Are you looking at it serially or just only initially for risk assessment? Are you looking forward to the software update for the skin thickness? Because I certainly see degraded bone architecture that I'm suspicious of in
Mm-hmm.
people with central adiposity.
Mm-hmm. So yeah, the trabecular bone score, which I think we've had now for a couple years, but now we have some insurance companies that are adopting it, and more. I think it's more readily available in the university settings and larger health clinics, which basically is again an adjunct to the bone mineral density that is looking at the actual density and calculating the areal density using looking at the vertebrae or looking at the size of the bones. And then the trabecular bone score is looking at, the best surrogate marker we have for microarchitecture or potentially quote unquote quality of the trabecular bone. So really primarily we're only looking at this in the spine. I think it has helped my practice when you ask me specifically, sometimes again, reclassify women who might be on the borderline of having, do we think they have low bone density or the term we call osteopenia and they're sort of tracking along, or do we think wow they're sort of losing more quality and losing more density than we think, and they really should be treated more like higher risk and we should really be doing something to prevent their bone loss. I also see that strongly with women who have secondary causes like rheumatologic conditions or have had gastric bypass or who have again, and it helps us realize like we should be looking for other causes of osteoporosis, particularly in women where you think, wow, you shouldn't have a degraded bone quality. Maybe the patients who are diabetics or very low vitamin D or hypophosphatasia, all these sort of maybe sometimes more rare bone health conditions. The tissue thickness, I think again, right now it looks at BMI when it's using its indicators, and then they're looking at again tissue thickness, and I think ethnicity also sometimes plays a role in what we're seeing for the TBS. So I think just like any new technology, it will evolve over time, but I do find the pictures to share with my patients when I show them what the density looks like and what the quality of their bone looks like and kind of where that meets in the middle. I think it's just more helpful in terms of our risk assessment, in terms of how we can share the information and help our patients understand what bones mean and what bone density and quality and fracture risk and why we even care about all these things.
Mm-hmm. One of our fellows, Dr. Rachel Novick, is actually what's her research project is looking at the patients that we've scanned in the center for 2 years and figuring out how many people diagnosis was the same regardless of TBS, or those that got better or got
Mhm.
worse, and then diving in clinically to see if we can see any more conditions other than the ones like renal failure and diabetes, some of the ones that we kind of already know about.
Mhm.
If we can find anything else in terms of making recommendations for cost-effective evaluations, or what things that people should think about, as opposed to just,
Right.
oh, it's you're a woman, or oh, it's just age. Do you have
Right.
any thoughts about about the ethnicity, um, independent? Do you think it's independent of BMI? I mean, I know we have so much less data because,
Mhm.
certain groups of women just have less risk of osteoporosis, whereas, other groups, particularly Caucasian and Asian, are more likely to have osteoporosis.
Yeah, I think like again, and I think that most of the data, like just off the top of my head, I think most of the data, like from U of C, which is like right down the sort of path for me, did a lot of this research and looking again that like yes, it seems like ethnicity does make an impact, and that's where potentially the tissue thickness will help further stratify. And I also think we know this from the SWAN data is that when women go through menopause and menopause, we know that we lose bone density, which we know that from, increase of osteoclast and decrease of the osteoblastic information and or activation. And we see that TBS, or the trabecular bones, or the bone quality decreases too. So sometimes when you say, have you checked it serially? I have seen that some women have started to lose, trabecular bone score who are opting to, not go on hormone therapy or just we're checking some serial evaluation. So I think that is something that also needs to be, talked about that, and hopefully also help again women who might have high risk for osteoporosis or fractures consider hormone therapy, as we know that that is one of the FDA indications for safe use of hormone therapies to prevent osteoporosis. And we see that again, the bone quality or trabecular bone score decreases with the menopause transition. And that's been nicely published.
Are you using bone turnover markers? Our lab recently stopped doing cross-linked telopeptide, which I found more sensitive than the CTX. I just
Hmm.
wonder, what are you using that? Because you
Yeah.
can only do bone densities every couple of years, generally
Hmm.
speaking, to see a meaningful difference.
Hmm. Yeah. Again, I think because most of my practice, again, having bone and body women's health, I see, a half or more of my patient practices, managing with more complex bone health issues or second opinions. And so they're either maybe sometimes starting medicines or coming off medications or unclear, what the benefit has been, or where are they at. So sometimes I will use bone turnover markers. That's type 1 collagen and telopeptide that's cleaved off when bone is resorbed. So 90% of our bone is made up of collagen. It doesn't mean you need to take collagen to improve your bone density. We don't know that yet. And I think that's something really important to say. We have a couple small industry sponsored studies that collagen does help bone mineral density, but we also don't know if just taking collagen alone is even being absorbed well and going to the places that it is. But that being said, that can be measured in the blood and has to be measured sensitively, as you know, fasting, generally not taking any B vitamins I usually say about a week before. And what we're looking at is to see how much bone is being broken down versus formed, and whether that's similar to what we're kind of doing in the premenopausal years and looking at the reference ranges. But it really needs to be interpreted with a with an idea in mind, with a question that you're trying to answer, because sometimes just random testing does not help us.
Yeah. So one of our previous podcasts was with nurse Rachel Ostermiller, who has had a baby boy. She taped that right before she was about to deliver. And she talked about just the nursing perspective and the patient preparation of infusion treatments like Prolia, denosumab, Reclass, zoledronic acid, monthly romosumab or Evenity injections. I wondered if
Oh,
you
good.
wanted to talk about what the latest in medications or things you see coming down the pike, or how you like to order the treatment, how much you're hamstrung by insurance. That always seems to be a recurrent issue, a thorn in our
Yeah.
side.
Yes. Yeah. We live in the insurance. I always say we have our ideal, sometimes medical world, and then we have the insurance world. And then we always have to also remember our patient is the perspective that matters the most. And sometimes that has to be above the insurance discussion as well. Um, So, and I want to listen to that. I'll go back and listen to that podcast because I think that, again, like our nurses, I have the most amazing medical assistant are like the boots on the ground, right? Like they are answering calls from questions, preparing the patients for injections, infusions, administering these. I've done plenty of that myself here, owning my own practice, giving medicines and things like that. Although you don't want me to draw your blood. But, but, but yes, I mean, these medicines, we have them. And so we use them in our armamentarium. So, you mentioned a lot of different, brand names and generic names. And now we are maybe in the next couple of years have some biosimilar options for some of these medications. So really when I think about them and like order them in my mind, again, we kind of talked about how we use them to affect our bone biology, right? So patients or women who are at the highest risk for fractures really need the medicines that are at least clinically proven to be the most effective at preventing another fracture and doing that very quickly and strengthening the bone quickly. And thankfully, we have now 3 options that do that. We have 2 options that are daily. They're a parathyroid hormone analogs and or similar or work similarly to our own parathyroid hormone to kind of stimulate intermittently making new bone or bone forming. And so those are, daily subcutaneous self injections. They sound, I think, very daunting to women until you, I think, explain why we choose them and show you why and how we do that. I have even had a patient with needle phobia go through hypnotherapy to be able to give herself the injections. And I think that shows you that there is definitely a way. And we do a lot of this education in our practice. And then also there's a lot online and a lot of these education services that can be shared with patients to do that. So that's a really great option for women who these medicines are both called teriparatide or abaloparatide. They both are
I
given.
was so disappointed when the patch study for abaloparatide Timlos was axed, but those needles are so tiny. And now I think more and more people are on weekly shots for diabetes and obesity treatments that it
Mhm.
seems like it's less of an obstacle to get over than it used to be.
I absolutely agree with you, and I think that we have seen, many people can give themselves a medicated GLP-1 or GIP medication, which is a weekly injection, or go, and those are titrated sometimes similarly that we titrate the osteoporosis medicine. So, I completely agree with you. These medicines are seeming a little bit more palatable, and they are so effective, right? So they both increase bone mineral density significantly, almost a whole T-score, like over 10% in a lot of cases, and decrease the risk of a vertebral fracture by in the 80s. So that's significant reduction. And generally they're used for 18 months to 2 years, but sometimes we use them longer for women who might be on steroids or have ongoing fractures, or who, might have, continue to have fractures on medication, and they're quite effective and safe. Certainly there's some women who cannot take these, like women who've had a history of radiation for like things like breast cancer or lymphoma, women who have high calcium or have calcium in the urine, etc. So, but these are very effective. And again, these are prescription medications that we can generally get covered very effectively for women who are less than 65. The cost should be very low. I just had a patient who said her copay was less than, I think it was $15 for these medications or less. So I think it's, again, we need to figure out, compliance, affordability, efficacy, safety. We have these really great medicines for people who are at high risk. We have another injectable medicine also in the class of the osteoanabolic or bone forming agents, which you refer to as romosozumab, which is given by a healthcare provider like your medical assistant or nurse monthly for 12 months. Just like you, this medicine is really interesting because it improves bone building, and it inhibits the bone resorption or bone osteoclast. And we have over 12,000 women studied in all different capacities, from 50 to 90 different fracture rates and risks. And so again, there's a lot of good efficacy in these medications. Generally, women who can't take these are women who have a high cardiovascular risk, like you have a heart attack or stroke, you have uncontrolled high blood pressure or diabetes, or you have AFib that's not controlled. So there are certainly some contraindications, but for women who are very high risk, we really are trying to choose one of these 3 options, because again, we know from our literature and our big body of science that this is going to be the best first choice for you, or the best option for you now.
So, how can someone become a member of your bone and body women's health practice?
Okay, well, lots of ways. I mean, I think the education that we give here is so important, and that's really one of the mainstays for my practice. And so my practice is in, like you said, in the North Shore of Chicago. It's in Winnetka. I have a DEXA scanner in my office, which has just been so lovely. And so I see patients from Chicagoland area, but I also see patients from a lot of like Wisconsin, Iowa, Michigan, all our surrounding states. Which has been so nice to come and make the medical experience and women's health experience so much more easy and enjoyable. And we have the time and the energy to spend, and I think that's so valuable. And then I also see patients virtually. I have a telehealth Florida license, so I see patients virtually, and then I also do consultations for women across the country. Of course, I can't prescribe in any state, but there's a lot of women who we can review your DEXA imaging and review, that from afar. It works very nicely. We can thank technology for that, and really get a second opinion on what is this. I'm not sure how this has been recommended, and I have some questions about that, or talking again about nutraceuticals, exercise, things like this. So it really, I think, doesn't have to be confusing. We try and make osteoporosis and bone health more understandable, and something within your grasp to really make a difference.
And tell us your Instagram handle. You've got great reels and information. It's lovely.
Oh, thank you. We try and keep it, scientifically based and authentic. I think that's so important this day and age. And it's Bone and Body WH. And then we also are starting some YouTube videos, which has been fun. So that's how you can find us. And my website, which is same names, boneandbodywh.com.
Well, thank you so much. We're so grateful for your support. And if you can share this podcast with others or leave us a 5-star rating to catch everything, be sure you subscribe or follow. It's all free, so you don't miss any episodes. And if you have a question or a topic that you would like us to discuss, visit speakingofwomenshealth.com and fill out the Contact Us form, and we might talk about your topic or answer your question in an upcoming episode.